Thank you. All right, Julia.
So, as I said, today we're going to be focusing on four main topics: sun safety, tick bite prevention, hand, foot, and mouth disease, and respiratory viral diseases. We can move to the next slide. Before I begin our sun safety and tick bite prevention topics, I want to remind everyone that per licensing, written parental permission should be obtained prior to the application of insect repellent and sunscreen. Make sure always to use a sunscreen that says broad spectrum on the label. Broad spectrum sunscreen provides both UVB and UVA ray protection. Always use a sunscreen with a sun protection factor of at least 15. For sensitive areas of the body, such as the nose, cheeks, tops of ears, and shoulders, try to use a sunscreen containing 15 to 20% zinc oxide or titanium dioxide. Try to choose a sunscreen with a fragrance-free and a hypoallergenic formula to avoid possible skin irritations. These products may stay visible on the skin even after you rub them in, and sometimes come in fun colors that children enjoy. We can move to the next slide. When applying sunscreen, make sure to use enough sunscreen to cover all exposed areas, especially the face, nose, ears, feet, hands, and even the backs of the knees. Because most people use too little sunscreen, make sure to apply a generous amount. Put sunscreen on 15 to 30 minutes before going outdoors, as sunscreen needs time to absorb into the skin. Use sunscreen during all times spent outdoors. Remember that you can get sunburn even on cloudy days, as up to 80% of the sun's UV rays can filter through the clouds. Also, UV rays can bounce back from water, sand, snow, and concrete, so make sure that children are always protected. UV rays are the strongest and most harmful during midday, so it's best to plan indoor activities then. If outdoors, when the UV index is the highest, between 11 a.m. and 4 p.m., try to find shade under a tree, umbrella, or stroller canopy. Make sure that children are wearing hats that shade the face, scalps, ears, and neck. If a child is wearing a baseball cap, make sure to protect any exposed areas with sunscreen. Children should wear sunglasses as they protect their eyes from UV rays. It is especially important to keep babies younger than 6 months old out of direct sunlight as much as you can. Reapply sunscreen every 2 hours and after swimming, sweating, or drying off with a towel. You should do this even if the label says waterproof, because there are truly no waterproof sunscreen formulas. Next slide. Baby's skin is more delicate and thinner than an adult's and burns and irritates more easily. Babies cannot tell you when they are too hot or beginning to burn and cannot get out of the sun without an adult's help. Babies also need an adult to dress them properly and to apply sunscreen. For babies and toddlers, use a mineral stick sunscreen containing at least 20% zinc oxide. Sunscreen in stick form makes it easier to swipe the product on the baby's face and hands. This is a less messy way to apply sunscreen, as there's no liquid or lotion to run into a baby's eyes and cause irritation. For babies younger than 6 months, use sunscreen on small areas of the body and remember to cover all exposed areas of a baby's skin, including the face, back of hands, back of neck, tips of the ears, and tops of feet. For babies older than 6 months old, sunscreen should be applied to all areas of the body, but be careful around the eyes. If baby does rub sunscreen into their eyes, wipe their eyes and hands clean with a damp cloth. If sunscreen irritates their skin, try a different brand or sunscreen. Babies younger than 6 months old should be kept out of direct and indirect sunlight because of the risk of heat stroke. Particularly, avoid having a baby out between 10 a.m. and 2 p.m. when the sun's rays are the strongest. Next slide. A baby's pediatrician should be called if the baby is younger than 1 year old and gets sunburn or develops a rash. A child's pediatrician should be called if a sunburn causes blistering, pain, or fever. Tick bite prevention is especially important if you live in a brushy or wooded area where ticks are present. If children have been playing outdoors, their skin should be checked at the end of the day and any ticks should be safely removed. We can move to the next slide. DEET is a safe and effective tick repellent. It can be used on skin not covered by clothing. Use products with the lowest amount of DEET, up to 30%. DEET is approved for children older than 2 months old. With children younger than 2 years old, their skin may be delicate and thinner than the skin of an older child or adult. Because of this, it is important to use DEET sparingly as needed. Never use repellents containing oil of lemon, eucalyptus, and PMD with children younger than 3 years old. Sprays in pressurized containers. Repellent on children's hands, as this may spread repellent into their eyes and mouth. Insect repellent directly on a child's face. Instead, spray a little on your hands first and then rub it on the child's face so you can avoid their eyes and mouth. And never use insect repellent on cuts, wounds, or irritated skin. Next slide. The longer a tick is attached, the greater risk it can spread bacteria if it is infected, so you need to remove it as soon as you can. Finding an attached tick might be scary, but there is no need to visit the emergency room or a healthcare provider for removal of a tick. To remove a tick, use a clean, fine-tipped tweezers or tick removal tool and grasp the tick as close to the skin surface as possible. Pull the tick upward with a steady, even pressure. Don't twist or jerk the stick, as this can cause mouth parts to break off and remain in the skin. If this happens, remove the mouth parts with tweezers. If you cannot remove the mouth easily with tweezers, leave it alone and let the skin heal. Clean your hands in the bite area with rubbing alcohol, soap, and water. Dispose of a live tick by putting in alcohol, placing it in a sealed bag or container, wrapping it tightly in tape, or flushing it down the toilet. Never crush a tick with your hands. Next slide. A child's pediatrician should be called if someone has tried and cannot remove the tick, or if the bite starts to look infected. And if within 30 days of a tick bite, a child is displaying symptoms of a rash, fever, fatigue, headache, muscle pain, or joint swelling and pain. Next slide. The Vermont Department of Health website has some fantastic resources for preventing tick bites. You can order educational materials for free from our website, which is accessible through that QR code. And the website will prompt you to share your child care's name and mailing address. Then you may select materials. These materials include packs of stickers, cards, shower and mirror clings, hiking posters, outdoor posters, magnets, booklets, trail signs, and reference manuals for healthcare providers. Next slide. As you can see, here are some of the examples of what those toolkit materials look like.
Okay, I think this one's mine. Hey, first of all, health department, beautiful materials there in the tick arena. I like the graphic design. Okay, it's our favorite time of year. Awesome childcare providers. Hand, foot, and mouth is a seasonal virus in the Coxsackie enterovirus family. Coxsackie is the name of a town on Route 87 when you're driving from Vermont to New York City. So if you're ever tempted to take that exit, that's where they discovered this virus. It's really a difficult thing to manage. And I just wanted to start by acknowledging you're probably already in it right now. And what we want to do is create a little bit of structure around how do you exclude kids and when is it okay for them to come back. So all the advice we give about the care of kids with hand, foot, and mouth is like the hyper alert for regular infectious disease protocols that you do anyway. And boy, does this bring me back to the COVID presentations we used to give. So this virus is famous for spreading like wildfire because it comes out of the nose, it comes out of your mouth, it comes out of your stool, it comes out of the blisters if they're not intact. And it's called hand, foot, and mouth because that's where we most often see the rash. This is a good picture because it's subtle. If you just look below that kid's thumb, you can see it on the chin. So practice hand washing, frequently disinfect all the stuff you do, maybe even more than there was a time when we really pulled back a bit on the hypervigilance to surfaces for COVID. However, this hand, foot, and mouth season requires a lot of wiping down of toys and doorknobs. we should always be careful about our own hygiene as it relates to the way we use our hands and touch our face. I'm sure you've seen the videos. I myself touch my face all day long. My husband's always pointing it out. So trying not to touch your face in general is a good way to avoid infection spread, but especially if you haven't made your way over to the sink in between the care of children. The tissues and the nasal secretions are particularly infectious. Those go ahead and go in the trash as quickly as possible. You have such a big role, as you do for all things children, in helping to teach kids how to maintain their own hygiene when they've got a sneeze coming or a cough, and then keeping the blisters clean and trying to avoid the picking or the wiping of the thin blister that would lead to the disruption of the skin around that's forming the blister. Next slide. Okay, so you actually taught me the most about this, but the really most important exclusion criteria besides fever, is this idea of participation, and that because this virus sticks around for, it can stay in your system for 7 to 10 days. Unfortunately, it also can stay in your bowel movements for weeks. So part of the reason why it's everywhere is because it has such a long incubation and also a long time in the human. So bringing a kid back or asking them to not be there is really about their ability to participate. We see a lot of challenges in the mouth with this virus where children really can't adequately hydrate or get food in, and that would be something you would observe and know we can't have this child here because of the drooling. And no matter how hard you try to maintain infectious control protocols when there's just drool dripping off a kid's chin on a hot summer day, it's impossible to prevent the spread. And then if you've got a kid whose blisters really aren't intact, that's a spread risk, as you know. Next slide. So we've asked a child to not attend for when they're in the acute phase of this virus. Now the parents are asking, and it's time to bring them back. And you can use these 5 criteria. Obviously, fever-free. We really need to make sure the kid's energy level is back and that you can have a fully participating child. The drooling, that's a hard one because some kids are droolers anyway, but it's really the change in the drooling pattern that would be the shift that the mouth wasn't healed, and that it would be also a risk for a child becoming dehydrated again in those days after the original infection. You want to see that the blisters, you don't need blisters to go away because they're going to be there for several days, but they need to be dried. And as long as you are in that driver's seat, you will certainly be able to make the decision that the care of a certain child with hand, foot, and mouth might compromise the health of others or your staff, other students or your staff, children. Next slide. Okay, I don't know who's doing this slide, Julia. Probably
So
someone at the health
John's
department.
content is
Yay.
next, but I did want to include a QR code directly to our respiratory viral disease website. There's some great important links on that website you can access, as well as facts, Q&A, and information relevant to childcare. So John, you can take it away.
Awesome. Thanks, Julia, for sharing that. And we can go on to the next slide. But first, I just want to say thank you, Breena, for vocalizing, for speaking for us hand touchers. I feel a lot of shame being in my line of work, being someone whose hands frequently goes up to my face. And you really, that the mighty Breena Holmes also struggles with this made me feel, frankly, a lot better about myself. So I appreciate that. So can we go to the next slide? I think yep. Okay, great. Perfect. So I'm going to be talking about really the epidemiology about, going to talk a little bit about COVID and the other respiratory diseases. And I say it's the epidemiology because what we do in Epi is really we give information about the activity, the spread of the diseases, and give guidance about reducing, cutting down on disease transmission. But what we're not is that most of us are not clinicians, and we don't want to be a substitute. We still want to encourage child cares and individuals to really have discussions with their providers about their own personal health and clinical So I'm going to talk a little bit about what has and hasn't changed 2024 with COVID and other respiratory diseases. Just give a quick overview of current COVID activity, quick overview of guidance of for COVID and similar respiratory diseases. So we can go on to the next slide. So what has changed in 2024? CDC and Vermont's Department of Health no longer report on COVID-19 hospitalization levels, but in Vermont, we do report on an average daily number of COVID-19 diagnoses that show up in emergency department visits. We found that this really closely correlated with the other indicators that we and CDC had been using in the past, so we still feel good about sharing this as an indicator of overall COVID-19 activity in Vermont for those Vermonters who are interested in monitoring this. Kind of a continuing pattern more than a change of continued immunization and infection-derived immunity. We're really seeing a reduction in severe COVID-19 sickness and in deaths attributed to COVID-19, which is fantastic. And there's really been more of an emphasis on positioning COVID-19 along similarly appearing and similarly treated respiratory viral diseases. Next slide, please. So what has not changed? A lot. No changes for infection prevention and control have occurred. Vaccination is still one of our best strategies to reduce the burden of COVID-19. We're going to have new formulations like we do with flu that'll be rolling out this fall. Not hearing about it as much, but often we'd hear a lot about questions about the new variant, press interest in the new variant. None of the recent variants have presented any need to change recommendations or otherwise introduce major changes. And like the previous couple of respiratory disease seasons, COVID-19 is going to be coexisting with other similarly presenting diseases. And I think folks have really learned a lot, but we still want to reinforce that some of these other conditions, particularly RSV, sometimes flu, can be of much greater risk to some of our populations, and particularly young children. So I know for the first couple of years of COVID, there was kind of a general sense of, okay, this isn't COVID, we're fine. We really want to reiterate that with the child population, these other diseases are, a similar or sometimes even greater risk. Next slide, please. Just going to show data on COVID-19 because COVID-19 doesn't have that kind of fall-winter seasonality. I'm tempted to say yet, but it doesn't have that pattern that we observe in flu and the other cold viruses, similar cold viruses, other coronaviruses, other diseases that lead to what we call colds. We've seen a slight uptick in COVID-19 activity recently, but it is still quite low relative to the pandemic and even quite low relative to the last year and a half, really. We can go to the next slide, please. For folks who are interested in tracking, wastewater is one area where we're going to continue to do a lot of tracking to get an estimate of how much COVID-19 infection is out there. That's really different from the amount of COVID sickness that's out there, which we capture pretty well with the emergency department diagnosis data that we showed. But for folks who are interested, we invite you to still come check out our COVID-19 data page. Next slide, please. Drilled this home the last couple of years, going to drill it home now, reemphasize it again. COVID-19 testing should not be required to send someone home from a child care or to let them attend. There's no public health reason for a facility, a child care, school to require a COVID-19, a string of COVID-19 negative tests to allow someone to return. Like with other illnesses, if a child or staff member has a fever or is otherwise too sick to participate, they should be sent home. For you providers and for others, you can go back to your normal activities after at least one day if you don't have a fever and if your symptoms are getting better overall for COVID and the other respiratory viruses that we're talking about here. And after returning to normal activities with COVID or other respiratory sickness, we do want to encourage folks to take extra prevention steps for the next 5 days. We can go to the next slide, please. So some of those are, I know a lot of kids in particular are too young to wear masks and participate actively, and that's okay. We can get around this. We can still add some prevention steps with ventilation, with spacing, an inability to wear a mask, whether it's due to age, another condition, perhaps a language learning issue. That shouldn't require a child to stay out longer than a child who is able to wear a mask. And again, like with, probably don't, we also just emphasize, a fever, a sore throat, vomiting, diarrhea. We don't want to see those in school, right? Even if it's, testing negative for COVID, fever's gone. If there's still sore throat, vomiting, diarrhea, we'd encourage folks to stay at home. Next slide, please. So again, the general guidance from COVID-19 to reduce the likelihood of infection for COVID-19 is really similar to the other seasonal respiratory diseases. It's the boring stuff that we remind people to do all the time. It's covering our coughs and sneezes, reinforcing hand washing, cleaning surfaces once a day. Not every disease is going to be spread that way, but there's a lot of germs that are spread on surfaces. Optimal ventilation is important. We've learned a lot about this in the last few years, the kind of air cycles and air quality steps that can really reduce the likelihood of spreading airborne viruses inside. Stay home when sick and stay up to date on yearly vaccinations, including COVID-19. Next slide, please. So we've got a few things we want to share. It's again, plenty of time before flu season picks up. But we do ask that childcares, schools, and other facilities revisit and review CDC and other public health guidance on how to prevent respiratory illness in their facilities. So we've got links here. I know these slides are going out, so we don't have the full URLs in here. And we also ask, make sure your illness protocols and guidance are up to date. Make sure the exclusion criteria are clear, that you and your staff understand them. Again, last year we do get a lot of questions about, when can someone come back? Check your protocols to make sure that's clear. And we're more than happy to work with you on these if your assistance is needed. Also, again, we do encourage you to talk to healthcare providers in your community. Talked mostly about COVID here, just because that's really the disease, that's really the one that's going around right now. But we have flu outbreak resources on our website as well. If you go on to the next slide, please. And childcare facilities that aren't schools and aren't healthcares are not required to report cases of COVID, flu, RSV, colds, but that doesn't mean you can't reach out to us. We'd encourage you to reach out to us if a child or a staff member in your facility is tested positive for COVID-19 or is otherwise sick and you want guidance or assistance. You can contact local health office. You can contact, if it's COVID, the COVID-19 program. Next slide, please. And we also, if it's a non-COVID, it's a flu outbreak or a respiratory illness outbreak of undetermined origin, you can fill out a form if you want help with that. And we've got some guidance on what to do if you do want to fill out a form here on the website. So you're not required to reach out to us unless you're a school or a healthcare facility, but you always can. We want to provide assistance and infection prevention and control if we can. Yes, with clinical questions, we want you to talk to a provider. We want to encourage those relationships in your community. But please feel free to reach out to infectious disease epi at the health department for questions about activity of diseases in your community and in the country, steps you can take for prevention and dealing with outbreaks. I think the next slide has some contact info. If we can go to the next slide. Yep, so we've got the contact info for the COVID program, for the flu program. And again, you can reach out to the flu program if you have questions about other respiratory illness that you might be confronting in your facility. And if you want to reach out to your local health department office too, we have 12 local health offices throughout the state with all kinds of great staff in there, nurses, epidemiologists, folks with real good relationships in their communities. And we encourage you to really use them as a resource as well. So thank you.
So we'd like to take this time to open back up if anyone has any additional questions, either related to the content areas that we just covered or other health and safety questions.
Hey, well, this is Breena. Look, I just touched my nose. Did you see that? I had an itch. When people are, as you're formulating questions, I'm wondering how that lands out in the real world, how COVID has sort of slowly or not so slowly become just a respiratory virus that you manage yourself, that you decide, you look at your symptoms, fever-free 24 hours, get back to it, as opposed to all those years of a very strict protocol about your behavior. I would imagine I still have the mental challenge because people call me, there's a lot of COVID around, people saying so-and-so had COVID. I get right into the like, uh-oh, where was everyone? What were we doing? How do we manage this? And then it just sort of fades into watch for symptoms, live your life. I think someone did have a question, Beth or Julia, about that. Is there anything we should be doing as there's been an uptick in cases? So I just wanted to make sure if that was your question, you hear that no longer is the sort of epidemiology of this driving any change in policy. It's still take care of yourself and right, John?
Yeah, and I want to, reinforce that we really actively monitor COVID activity. We have more resources for monitoring COVID activity than we do other similar illnesses right now.
Yep.
And we still really actively look at this. So we get positive COVID test results from a healthcare provider. We know we're going to see less of these for a couple of reasons. One of which is that people are getting less and less sick with COVID, so they're less likely to see a provider when they have it. So we don't want to say that, 10 reports today is the same thing as 10 reports would have meant 2 years ago in terms of COVID activity, because it's not the same. But it does give us a sense of when activity is going up, we have a signal there. Again, with the emergency department visits, not everyone is there for COVID, but we're not doing routine testing for COVID-19 for the most part. So that does give us a good sense of when we're seeing people sick with COVID-19. Gives us kind of a, again, a signal more than a specific number that we can tie things to. So we still are really keeping an eye on things. And when, if we were to see a really large increase that, we don't have those levels anymore, like medium, high. But if we were to see a level of activity that suggested widespread COVID-19 illness and, increased risk from COVID-19, a large increase in activity, we would make that public. We would reach out to healthcare partners. We would post that information. We do post that information on our website still. Every week we update the information on COVID-19. We have conversations with, we're not in a position to require places to require masks or anything like that. But, during respiratory seasons, we're going to be talking about, hey, when do we want to make this a recommendation for everyone? And when the data warrants it, we will make that a recommendation for everyone. And we, again, we encourage folks to talk to their providers if they have their own concerns, own health risks. There's nothing wrong with wearing a mask just because, you're concerned about it, or you felt a little under the weather and you aren't sure if you got an allergy or not. We really want to encourage folks to take the steps that they need and that they want to do. And we will communicate if we see a large increase. We're seeing an increase now, but again, part of that is because we're still really looking for COVID in a way that we're not looking so much for other illnesses. And part of it is because it doesn't have that seasonality. So we're going to see maybe a little upticks in the summer, but it's kind of a long-winded answer, but I hope that cleared things up a little.
No, it's really helpful, John, because what I'm thinking about with these great colleagues, and Jen, I see your comment in the chat. I'm definitely going to get to that. I imagine that these childcare providers are getting, their staff is calling and saying, I tested positive for COVID. I'll see you next week. I'm going to take the 5 days, which, this is a hard thing for me to say. I think it's easier for me maybe than John, but the person doesn't have to be out 5 days if they're symptom free. And yet, if that's a little bit of a gray area and the person comes back and isn't masking, that's a risk to the children. That I would imagine that's a tough spot. John, do you have any thoughts on that, Becca or John?
Oh, sorry.
Either. And Becca's got her hand up too.
So I would say, there are different requirements and different recommendations for healthcare facilities. So for instance, the requirements in a nursing home or a hospital are significantly more stringent and more specific than in other settings. So they do have some of those, and we, healthcare facilities, can, again, we're gonna, right, as Breena alludes to, as the health department, we're gonna urge a lot of caution, right? We're in the business of mitigating, stopping when we can infectious disease spread, and we understand that, facilities, individuals have other concerns that they need to balance. But there are specific requirements for healthcare facilities.
What do you think, Beck? Nothing more on that, yeah.
No,
Yeah.
no, yeah. Yeah. Jennifer, I put there's sorry the link is so weirdly long, but and I think we were already going to put this in the notes, but information for parents about hand, foot, and mouth. But Breena, I don't know if you have anything else beyond what you had said earlier to add.
Well, I'm really interested in the pediatrician, childcare provider, early childhood educator partnership, because I think the amplification of each other's experience and also the way that you're communicating with parents really matters, that we get some alignment here. So that was what came to mind, is if you're really, if we can help you, Becca and I have a really strong connection to pediatricians all around the state. And if we can help you find a early childhood champion among your pediatricians that can really support that observation, that childcare is in a tough spot and that there's a fair amount of spread and that we really have to attend to the virus at hand, I think you would feel that the support that you would need to tell parents they really can't come back yet. And the health department district office, as John discussed, they're another great group of people who will just come alongside you. I think having the information and educating parents is what you do every day, all day. And this is a great handout that Becca included. But I can hear from the question that there's like a space in between when the parents are like, oh, come on. Much like we experience with other viruses like COVID, they're like, you have to take this kid back now. I've been out of work 5 days. So that pressure on you, even with the facts available, would feel better with a team. Just a couple of people that come together around this, because it's pretty short season for hand, foot, and mouth. I shouldn't say that though, because it often dribbles into the fall. And it's such a disaster. It's just, it's so familiar. And pediatric offices are so funny because obviously you need and want to support families who want to be seen, but we had such trepidation about having those kids in the waiting room, that actually led us to divide our waiting room. You know how some offices have a sick place to sit when you're sick, which is pretty stigmatizing, by the way, and not best practice. But we had to do something about the drool. I could just picture it, which of course you're there all day, every day with the drool. So that's a recurring offer from Becca and Breena through Beth and Julia. Just call us and say, I live in the Northeast Kingdom and I would love a pediatric partner, and we'll make that connection for you, because I really do think Vermont works best when we're on a team.
I have one other thing I wanted to mention. I kind of want to put John on the spot. We didn't talk about this beforehand, but as we're talking about things like not being so specific about certainly the respiratory viruses, which, I totally agree with, what we see in kids who need to be hospitalized are things like not now, but it's RSV, it's flu when flu is here. Right now it's rhinovirus, metapneumovirus, all the viruses, adenovirus, those types of things, and not really COVID. But there is one thing that you may have heard about in the news that's not a huge problem in terms of an outbreak now, but would affect your patient population and you would want to deal with it differently, and that is measles. And that is because children they don't get their first measles vaccine until they're like 12 to 15 months, if they're even like following the schedule. And so that is certainly something the health department would like be in close contact with you about. If a family comes back and they're like, hey, I heard about, I was exposed to measles. The health department is tracking that very carefully. The epi team is tracking that. There's just been a couple of cases, but I just want to put that out there. That is something that's very specific. And if you hear about it, if parents ask you about it, it's just the vaccine is so good for measles. So just like the key is just like make sure that, you're just talking to parents that pick up and drop off and all the time. And I think you're such trusted resources. And if they talk to you about this, I mean, the measles vaccine, it's so effective. It works so well. Once you're vaccinated, you are so protected against measles. So, and I can put some information about measles in there, but it's not, and I'll have John, like the health department's all over knowing like where the cases have been and all that, but that is just something that's really different than something like tracking COVID and these other diseases.
Yeah, that's a great point, and thank you for raising it. I mean, it is so contagious. And we went so long without seeing cases, and now because vaccinations are dropping off, we're seeing it again, and we'll probably see more again until we can get greater vaccine uptake going. So yeah, please, we really want to encourage vaccination for this. Like Dr. Bell said, it's a very effective vaccine. It's also it was very effective when everyone was getting it as well, and we really weren't seeing cases. So it is possible for an individual who received the vaccine to at some point get the vaccine, gets many years on, we see like older individuals who may have had one dose or an incomplete dose or aren't clear about whether they got the dose or not. The vaccine regimens right now are so clear. The quality of vaccines we have are so good right now that it's incredibly valuable, not only for yourself, but really for your community, for that neighbor of yours who maybe got it a long time ago but is immune compromised, or maybe thinks they got the vaccine but didn't. So please encourage this. And if you're not vaccinated for measles, please do so.
And then the other thing I wanted to just get opinions about is that, so our next meeting, Julia had said, is in September, and that is when we're going to start embarking on respiratory viral season. John gave like a little teaser and just the way we think about it, but we do have a season for pediatric illnesses around respiratory viral stuff. It is really seasonal. It's been a little bit, RSV has started a little bit earlier in the past. 2 years ago was pretty early. Last year, it still always lasts for about 12 weeks. It's like the worst time for me personally, in terms of how busy we are in the ICU. So the cool thing about this upcoming season is that we do have two things that can really help our population. The kids that get the sickest are the young kids, the kids you deal with. So we've got a monoclonal antibody shot for infants that they can get their first year before their first RSV season. And then there's also a vaccine for pregnant people. And so we're going to talk about that more in September. In the meantime, I would love to hear from you because you are our connection to the people that are affected most by RSV. I would love just to hear how you think parents consume information. Is it like a newsletter from you all that we can give you some information that you could put in your newsletter? Is it additional handouts? Is it like little videos that we can share? Like, what is the way that people want to consume information specifically about RSV and the vaccine and the monoclonal shot? I think we didn't do a ton of from a public health standpoint and a provider standpoint, we didn't do a ton of outreach about these products last year because there just wasn't enough of it around. And so it was like hard to encourage people to try to get it when we didn't have enough of it. But now we do have enough of these products. Last season, the folks that got these products, these preventative products, really saw a decrease in hospitalizations due to RSV. So I would love just to hear from you all, like, what can we be doing as a group here in sort of getting ready to give information to your families? Because I will tell you, the kids that end up in the PICU and the ICU on a ventilator intubated with RSV are the new babies with siblings in childcare. Like that is just like the classic. It's like a baby who's 1 month old who has a 2-year-old sibling in childcare, and like RSV is everywhere and they get RSV very young. So I'd love to think about like how we can, these are your families, and I'd love to think about how we can, personal conversation. That's awesome. Okay. So, and so then my next question, Jennifer, is like, how do you best want to hear about this information? So part of it is sort of like a, train the trainer, like we talk to you about this so you can have good conversations. So we'll try a bunch of different things. And I think like through with the health department, Brina and I, we would love to think about how to like get this more information about this out there, because I think we could really start to change how RSV season looks in a way that really keeps our kids healthy, which would be awesome for everybody.
I think that
Thanks.
that
Yeah. Thanks.
scenario that you raised, the pattern that you see is so important, and maybe we should even think about that being part of our messaging as a department going forward, because that's what you're seeing, and that's it's very moving, it's very compelling. So thank you for giving us that kind of that detail that doesn't necessarily show up in the available data.
You guys are going to think I'm a broken record, but the partnership again, that feeling that there's messaging coming from pediatric healthcare at the same time you're all messaging the same sort of, hey, it's hard for the whole community when young kids get this respiratory virus for all the reasons stated by Becca. So I'm going to keep wondering about how we can amplify those voices. I also do wonder about your sort of the timing and your ability to get out ahead of this. That's what Becca's bringing it up today. We had said we'd address it in September, as she said, but kind of feels like a calmer conversation can occur now, as long as you're not experiencing hand, foot, and mouth. When you're experiencing a little less of the illness and the stress on parents is a little different, you might have an opportunity to say, hey, there's this cool thing. So we can also get those resources to you sooner than later. It's really, from where we sit, Becca and Brina, it's kind of life-changing. Something like this comes along every 10 years or so in the infectious disease world. You're like, wait, what? We can actually prevent hospitalization. And yeah, same thing with when, I'm old enough to remember the Haemophilus influenza. There was a type of meningitis that we used to see like 10 kids a month, and then the vaccine came and we never saw it again. So cool. People forget those stories.
I mean, even rotavirus, which we tend not to think about being, a huge deal, just an annoyance. But I don't think of myself as being that old. But when I trained every spring, we would have just like a floor of patients just there for rotavirus, for IV fluid hydration. I did have kids with hypovolemic shock from, the vomiting and diarrhea that happens with rotavirus, and it's just gone now. There were so many hospitalizations for rotavirus. I mean, and that was just, anyway, it's pretty amazing. It's pretty amazing.
Becca added to the chat, if we can get messaging out to families a month before we would want the flu shot to be administered, they can start exploring when and where to access that, being proactive. And then continued follow-up and reminders to families and staff.
That's helpful, Becca. The other Becca. I think the space there is, we just want to make sure, and the health department's a great partner in this space. We got to make sure we know what the availability and where it is and how to get it before we start promoting it, or maybe at the same time. It's just last year, I think Becca said this had a little glitch to it, like all good ideas, some implementation challenges, but not this year. 100% no. We're going to get it to anyone who wants it.
So Julia has provided her contact information here for additional questions. Just to reach out. Go ahead, Julia.
So thank you, Beth, for your support and technical assistance. And thank you to John, Brina, and Becca for your expertise. Thank you to everyone who came to the webinar today. You're the experts on the well-being of children in your care, and we continue to learn so much from your questions and inputs in these meetings. We'll definitely look into the questions and suggestions given in the chat today. Our next meeting will be on September 19th. In the meantime, please reach out with any health and safety questions or recommendations for future topics. Even if you want to contact John, Becca, or Brina, I can filter those messages and make sure they get to the right person at the health department or from our colleagues. So thank you again. Any questions in the meantime on any of this content, future content, RSV, measles, please reach out.
Thanks so much, everybody.
Thank you.
Thank you.